Good morning, everyone. It is really exciting to see this group of people at what I know is the third year of this meeting, which keeps growing and growing. And I think it's growing because all of you recognize, and maybe your jobs rely on, the importance of measurement in healthcare today. It was not that long ago in our three careers where measurement was an academic exercise. And that changed pretty dramatically about 20 years ago. And today, we rely on measurement for everything that we are trying to do in healthcare with respect to value. We rely on measurement for value-based payment. We rely on it for product design. We rely on it for transparency tools. And yet there is tremendous discontent with the measures that we have today. And we still call the measurement field something that's in its infancy, even though it's been a few decades at this point that we're using measures for high-stakes purpose, like payment and public reporting and product design. The concerns about measures are many. There are too many measures. The data being used for measures are of concern, and the timeliness related to that. The focus of measures being on process as opposed to outcomes. So we absolutely have, I think, consensus now in the field that we all want measures that move to be more outcomes oriented and that use clinical data. But our problem has been, among other things, that clinical data are a mess at the moment. Hard to access, not standardized, despite the tremendous work of HL7 for 20 years, more than 20 years. 30 years. And so the coming together of these two organizations, NCQA and HL7, for purposes of really advancing the use of digital information for quality and for quality measurement is an historic one. It's profound, and the opportunities, I think, are really, really tremendously exciting. And in fact, it's probably not an overstatement to say that the goals that all of us have for where we're trying to get to in healthcare depend on the success. So I'm really thrilled to have the opportunity to moderate this panel with these two leaders. 30 years ago, NCQA similarly had its work cut out for it with respect to standardizing claims-based data, which were in no shape to be used for measurement, and NCQA had an agenda to begin using them. And today, of course, claims data are highly standardized and very useful for measurement. So we know it can be done, and I'm thrilled to have the opportunity to talk with these two leaders about their vision for collaboration. So Peggy, let me start with you and just ask you to tell us a little bit, how did this collaboration come together, and what would you say it makes possible that's otherwise not happening today in measurement?
Yeah, well, I have to call out Ben Hamlin, who's standing in the back of the room, who has been working with us for many years and who has had a lot of vision about getting to the clinical data. There are so many reasons why we need to do this. One is there's a lot of activity going on at the delivery system level that we want to know more about, and we can't possibly know it from claims data. Two, the burden issues. Until we reconcile and align measures and really have common data flows and so forth, which feels far away today, it's not going to maximize the utility of the data that's there. And people are going to be using different measures for quality improvement, and it's kind of like what we see right out there now is a cacophony of data and measures that are driving people nuts. So we have a responsibility, and we're so grateful to HL7 and to Chuck for working with us, because we do think that our kind of working together holds a lot of promise. There are also things that we'll be able to measure that we can't measure now. I'll give you an example. Laura Esserman at UCSF is doing wonderful work on risk-based breast cancer screening. So It's instead of the current measure, which is about how many women over 50 had a mammogram in the last 2 years, basically. It's kind of developing a risk score using some genomic data and then screening according to your risk status, which is a much more sophisticated paradigm, and which is really, I mean, we can imagine these things, but we can't actually use them for any kind of accountability now, except maybe in a little boutique experience, So in order to make measurements stay meaningful and really keep up with the potential that I think is being unleashed right now in healthcare, it's really urgent that we get these data aligned. So,
Thanks.
Can I just ask one question? Can you raise your hand if you're from a health plan? Dana asked me, and I didn't have it, so you can see a lot. If you're from an auditor, okay. If you're from a data company, perhaps that works with health plans, or data company in general. Okay, so that's a good sense of the crowd. Thank you.
Peggy. So Chuck, tell us a little bit about what's in it for HL7 to be having this collaboration. What really led you to want to do this? And what are you most excited about in terms of what you see as possible with what you and NCQA might do together?
Okay, gladly. I think there are three broad goals that make this such a visionary process. One is claims data is absolutely inadequate for predictive analytics, whether you're talking about risk adjustment or payment systems. And bringing clinical data to the fore is the future of understanding how we're going to enable value-based care. The second is the coalescence of interest groups around the capabilities of FHIR. Less than a year ago, we started the FHIR Accelerator program. It enables verticals which had viewed themselves as unique, so genomics, population health, cancer, the payer-provider access around the Da Vinci Project, and many others, to realize that the kinds of data that they needed to exchange fell within rather narrow bounds, and this could be accomplished both from a technical perspective and also from a data quality perspective. And I think the third, which John Halamka alluded to yesterday, which is even more exciting, is building a composite picture of our expenditures, our process, the quality that we engender in patient care, and actually providing evidence of return on investment for the work that we've been doing, because I think we'll see the first significant bump in improving data quality, but also the quality of patient care.
And do you see this collaboration as really leading us toward measurement that goes beyond process to measuring outcomes and really in a patient-centered way?
Absolutely, absolutely. Having said that, I think we are in for a profound transformation of how we practice medicine in this country, because I think we're going to see that the outcomes may be telling a different story at times than the kind of standard process that we're currently measuring. So, it's a time, I think, when many paradigms are being dislodged, and we can all envision something, but we also have to hold on to a sense of steadiness and of doing what we can today without closing off the possibilities that are important for tomorrow. I just want to say to all of you who make this stuff happen, NCQA, we're the standard setter, but it's you all who make it happen. And that we want to reassure you that we are committed to doing this transformation of HEDIS and digitalization of HEDIS in a way that is going to be possible for all of you to succeed and to be excited about your work. So I know I sat in a session yesterday, I won't say which one, but it was way over my head. And, you know, so I just feel a lot of empathy for people that are thinking, oh my God, my job is hard enough with the Rube Goldberg situation we currently have for HEDIS, and now it's going to be something different. So I just want to reassure you that we are extremely committed to making this transition work for you. So thank you for letting me put in a plug.
Yeah, well, that's actually a segue to where I wanted to take this conversation next, which is, you know, these two organizations can't do this alone. And so I'd like you to, each of you, to talk a little bit about, for this to be as wildly successful as you're committed to it being, what do you need and who do you need it from? So what do you need from payers? What do you need from providers? What do you need from each other? What do you need from patients or consumer advocacy organizations? What do you need from data companies? You know, what's it going to take to really make this as successful as your commitment intends? Chuck, do you want to start?
Yeah, I can summarize it in one word, trust. I've worked in a lot of different segments of this healthcare continuum. I can tell you that at the clinical level, physicians and nurses and other healthcare providers don't understand how they'll be compensated in a value-based environment. We could predict the outcomes of patients in Boston just by using their zip code. The impact of social determinants on healthcare delivery, health literacy, clinical quality is staggering. And so if we're going to measure and report outcomes, how do we adjust it when the clinical environment is plagued with, well, I take care of the most difficult patients. How can I be judged on outcomes? I think the other side of the coin, which is really has begun to come to the fore, is the massive amounts of data that, let's just call them inconsistent. Certainly not have the usual kinds of demands that other industries do when it comes to defining a data point. That's going to be a challenge because medicine is difficult. Who knew, right? But the words we use and the things we mean are different for different people and different audiences. And so as we begin to struggle with this, I think we'll have to better align what we mean when we say things. Like, how many people in this audience have an allergy? Want to raise your hands if you think you do? I suspect that 75% of you are wrong, but I'll just go out on a limb. So the issue is all of the players need to agree upon what we mean when we say things, and I think that's going to be a challenge for delivering quality metrics and the kinds of outcomes that we envision.
Yep. This is why NCQA was created, was to align quality measurement and quality requirements more broadly so that we wouldn't have to have each, I mean, it started with purchasers way back, and each of the purchasers was going out and doing little tours of health plans and collecting their own unique quality measures. And, you know, a visionary purchaser, Pat Naismith from Xerox, said, this is insane, and we're driving people crazy, and they don't even have time to improve the quality because they're too busy measuring it in 100 different ways. And so it does take, I mean, alignment sounds good and it's hard, because I think there's a common problem in the quality universe, maybe in the general universe, which is that we all see ourselves as kind of the central player. And so there's a kind of need to sort of stop being rigid about what it is, try to figure out how we're going to align. At the provider level, I think, I mean, with payers, I think there's a need to embrace the data that's now going to be available at the provider level, because it's going to unleash a lot of potential. For providers, there needs to be a common data model, you know. So Ben had me watch some videos about OMOP. I don't even remember what the outcomes management, something. But it's actually very intriguing, and it allows different organizations to code their data in a similar way so that they can do collaborative research and real-time discovery from practice. I mean, talk about mind-blowing potential. And yet, you know, we still have everybody kind of with their own unique data system. So the trust, I think, is something that we have to keep earning every day, because all of us can blunder. I don't see that there are a lot of bad actors in this space, but people can make misjudgments, and we have at times. So we have to be constantly asking, listening, being open to criticism, even if the criticism feels unfair, because we're in such a very complex enterprise right now. This is going to be the kind of mantra for us, and I think we all need to share that if we're going to move this big ship forward.
Great. One additional question, and then you all be getting ready, because we're going to open this up to what questions you have. But if something could go wrong,
It will.
what?
Absolutely, absolutely.
I didn't mean Murphy's Law. I meant, what's your biggest fear about a barrier out there that you want this audience to be aware of, and you want them to be thinking about today in their working sessions, and the end of the week when they're back at their desks? Chuck?
Well, let's start out. I'll go out on a limb and say Murphy was an optimist. I believe that the kind of critical thinking that we need to be successful is going to take a lot of compromise. People have too much at stake in the status quo. The important changes that are taking place before our eyes will only be appreciated in retrospect. But if we're going to enable them, then we'll have to find the commonality that really drives all of us. We're all patients. And at the end of the day, it's really important to understand that if our goal is better care, what do we need to achieve it?
I have a long list, but I'm going to call out trust by patients. And I think we're going to see, well, if there are the obvious issues of privacy, which I think we haven't thought about enough. And, you know, it's not going to take many episodes of somebody's personal health data being breached for people to become very leery of the whole situation. I think that there's a lot of talk among tech heads about, you know, I own my data, but you ask any person on the street about what are you going to do with your data, I mean, it feels a little bit crazy at the moment, you know, so maybe I'm missing the sort of what's in it for me part of it. But I think we have to have not only acceptance by the public that healthcare is going to change, but also I think a belief in the possibilities that are going to be opening up here. And I do worry about a disparity between places like Stanford and Harvard and so forth, Mayo Clinic, Cleveland Clinic, just to call out some brands. who are, I think, going to move forward in a very mind-bending way, and what's going to be happening with the average practice of medicine. And I don't know how that'll play out, but I think it will cause some, serious issues for our system, and also for patients who, I don't know how they're going to judge that. It's probably going to segment itself and so forth. So I think it's time of potential confusion and maybe undermining of trust because of that. And I think we just all have to accept that we're going to have to be working that front very hard.
Yeah. Chuck, I know you have something you want to add in, so hold that for 1 second. But just let me stay on that for a second. So Peggy, if you were writing a billboard or a short one-page glossy document for patients that said, this is the future you can look forward to because we're going to be able to measure and create accountability for outcomes, what would you say that would help patients win their trust but also get them excited about the possibilities here?
I guess I would say, you've heard a lot about precision medicine, and we are opening up possibilities where your unique constellation of factors is going to be driving your care more, and we're going to need you to be more engaged with that. And that's not going to be welcomed by some people, I think. Yeah. But, I think we need to present it honestly as you have an opportunity to really benefit from this new paradigm of healthcare. And we pledge, and maybe there has to be some, certification or something like that. There are such things. We pledge to be trustworthy, to act in your interests and not in our own, and so forth. It sounds a little...
Yeah. No, that's bold. Chuck, there was something you were going to add.
We have to be more inclusive in the way we care for all of us. Rural medicine is a tremendous example of poor access to care, clinical capabilities, knowledge factors. We have rural medicine here in Boston, where the providers and the clinicians have language barriers and other issues. But in order to break that down, there are some regulatory issues that certainly could be addressed. So if you're a licensed practitioner in Massachusetts, dare say you need one in Rhode Island, Vermont, New Hampshire, and Maine, if you actually want to care for patients in that state. As telemedicine becomes more important, will drive up quality of care. Telemedicine isn't just seeing your patient on the other end of a cell phone, but getting radiologic images interpreted by the most capable people, having pathology specimens read by a group of competent pathologists. And that can only be achieved if we reduce some of the regulatory barriers. It is unimaginable to think that, because you can drive to Rhode Island, but to think that if you wanted to take care of someone in Rhode Island, you need another medical license. And so that's just a tip of the iceberg, a kind of issue in which we have barriers to actually moving ahead in a meaningful, forceful way. And I think while we're including the various players in this, and Peggy has mentioned virtually all of them, we still have to deal with a host of localized demands that emanate from state and regional governments that preclude the progress until we overcome them. So
Yeah.
I want to include those people in the discussion.
Yeah, that's a really important set of points. Thank you for that. Okay, so questions?
We've answered them all.
Yes, please.
Do we have a roving mic? Yeah. Please say who you are.
At HL7, we have an exciting new player within the Fire Accelerator program. That group has really coalesced of somewhere over 300 different organizations that believe the social determinants are important in the delivery part of the paradigm. We'll certainly see it clearly enunciated in the quality part once we get over the initial hurdle. They're trying to define the way we talk about social determinants. And they have a very exciting agenda ahead of them because they've been all been able to put aside their parochial interests and focus upon the commonality of delivering concepts around social determinants in this entire clinical discussion.
I just want to say that we've been doing a lot of work on social determinants for CMS and finding very interesting results. And I mean, it is amazing to me to see how much is actually happening on this front. There are new Z codes for social determinants that I think people feel very positive about. Arizona, Tom Betlak, who was the Medicaid director in Arizona, is on our board, and they had a project with United Healthcare in Medicaid where they paid for housing, they jointly paid for housing, and they had people co-located, many of these people with behavioral health diagnoses, and they were able to put practitioners in the building and have had tremendous savings from that. So, I mean, I have a constitutional objection to adjusting away differences, but I do think that we have to acknowledge that the challenge is more with some populations than others, and we have to give practitioners and organizations the means to take on the challenges. So I'm in favor of social risk adjustment of payment, as they do in the UK when they're allotting money to the NHS. They take into account the social status of the people in a particular area, and poorer areas get more money. So I think, to me, that's it's a tricky business to adjust away things that ought to be dealt with.
Yeah, I'll just add one additional piece onto those really important comments from both Chuck and Peggy, and that is to say, I think that part of why we see social determinants so widely talked about and now beginning to be acted on is because of the shift in healthcare measurement to outcomes. Because when we were just talking about process and what happened inside of a building, really didn't have to think about the individual and their life outside. But when we start to create accountability for whether we're actually producing health with our healthcare dollars, you find that provider organizations and payer organizations are beginning to reckon with the fact that you have to take into account the social determinants of health. And so I think that this collaboration, which makes more possible the measurement of outcomes through the use of clinical information, is going to only accelerate the bringing together of healthcare services and the rest of life that are the social determinants, and how we think about that and how we use that in the ways that we take care of people to actually produce health in our population and not just health care. I see a question in the back.
Can somebody get her a mic, please? Thank you. Can you say who you are?
Yeah, well, thank you. Yes, Peggy. This is Maureen, Precision for Valley. Good morning, everybody. I was listening to what was being said about social risk factors, social determinants of health, and I think it's really important what you were saying, Peggy, about making sure that we don't decide to use social risk factors perhaps as a reason for not performing well. But rather, I was wondering if you could comment, if anyone from the group here could comment about how do we use social risk factors not only to address their potential adverse impact, which is very powerful, but also are there ways that we can measure social risk factors to identify them as strengths so that we can leverage them also for better health? Because many times, certain risk factors may be adverse risk factors for us, but the same patient may have some real positive strengths from a social risk factor perspective that could help move advance care as well. So thanks, appreciate it.
I mean, I think that it's really important, and this is kind of an old saw in medicine, we need to understand the whole person. What are the assets that person has? Maybe the person has a wife or a child who is really interested in being engaged, and sometimes that person feels like they're working against the system. So, you know, a real recognition of like, who is this person, who are their family, how can we optimize the synergy between us and the support systems the person has. That is what we all want, right?
I think that in some ways there's a big gap in social determinants in which we fail to evaluate healthcare literacy. We have an epidemic of measles. It's not amongst people who are unable to access clinicians. It's not people who don't have the ability to pay for it, and it's not about people who have a compromised educational background. It's about people who make this choice out of ignorance. And that's an important social determinant. I could go on other problems other than the measles outbreaks. Half of all women who've had successful remission of breast cancer don't put the free adjuvant chemotherapy pill in their mouth, even though it has virtually no side effects. The reasons are obviously complex, but we have to build on the huge educational gap that we see in understanding of what it means to be well. And I think that's a social determinant that I'm not sure I can code. So we'll face that one, but I think it's a real critical one.
More questions?
So I'm going to ask a question. So Ms. Gail, we had a little bit of conversation earlier in terms of really performance management and kind of with the digital quality summit, kind of progression with very unstructured data and natural language processing. Where do you guys see that going in terms of performance management?
Do you want to start?
Sure. In the last decade, the progress in natural language processing to address unstructured data has been remarkable. Not only do you simply capture the information, but some of the natural language processing has been able to capture the context. There have been some experiments in which clinical encounter was video analyzed for the expression of the patient. the gesticulation of the clinician, to add content to what the question was and how it was answered, because that's all unstructured data. And as we move ahead in that kind of science, I think the distinction between unstructured and structured data will start to diminish.
We're very excited about the potential here. We had folks from UPMC come in and show us what they were doing. And I know there were 2 other organizations that came in to show us. We think this opens a lot of possibilities, and maybe we can get away from some of the check boxes that people are so upset about. So we look forward to advancing and learning about what's happening and trying to put it into wider use.
Good morning, I'm Zanita from Minnesota. I have a sort of a provocative question, but before that, I'm going to preface it by a comment that I'm certainly fully in support of the precision medicine individualized care movement. My question is specifically its potential impact on the measurement the way we do it today, because we sort of have been convincing physicians for the last 10 years that no, your patients are not unique, that a certain cohort needs to have standardized care. And we're spending billions of dollars to bring out variation in care. And to me, the ultimate extreme of this type of individualized personalized care is when a patient is their own control. And what happens to this entire framework?
Yeah, I think it's indeed a provocative and difficult question, and I think there will be a lot of hype. I mean, as we know, there's no shortage of hype in the current paradigm, and so I think we can expect there'll be a lot more, and it'll be a lot harder to identify it as hype in a precision medicine context. But I think we have to be committed to honesty and to learning as we go. And as we're learning, I mean, the work that I talked about before with Laura Esserman is extremely compelling. And if that paradigm is allowed to flourish, a lot of women can be saved, a lot of aggravation, and women who are at higher risk will get the screening that's important for them. So there are lives at stake, and we need to just kind of be learning from the data as it emerges, and we need to be changing measurement as we go. And I don't know what that looks like at the moment, to be honest with you. And it's going to be very awkward to have dueling paradigms out there and talk about accountability. So it's a great question and one that we need to take very seriously. Thank you.
Chuck, you have a comment?
Yeah, if the hand-raising exercise wasn't sufficiently revealing, let me put in a little plug for a technical solution to this. HL7 and its collaborators have developed a technology that we call CDS hooks, Clinical Decision Support Hooks. You don't need to know a whole lot more than the acronym except to say that it's about bringing disparate data into the clinical workflow without the provider actually knowing where to find it, how to look it up, how to access it, whether they have remember the passwords, all of the constraints that go on having a broad variety of data can be brought to the desktop as the patient is cared for, whether this is a social determinant, a genomic SNP from precision medicine, or even an exercise in clinical understanding of the patient or the clinician. And so that technology, which is rapidly emerging, is going to change the way we encounter the patient. And so I just want you to walk away saying you heard it here. Thank you.
Yeah, if I could just add and synthesize, what Peggy and Chuck are saying, and to your point, I think the issue is not that we are going to swing from a place where every patient, in a particular cohort was expected to have the same identical care path, all the way over to another extreme where you just are kind of relying on the art of medicine to create your own sensibility of who is this person and what's the right thing. We're actually going to stay in the world of knowing what the right thing is to do. We just have more variables. So it's still probabilistic. It's still based on cohorts of patients and what the right care is for them. But those cohorts are defined with many more types of variables and things that didn't used to enter the equation, like social determinants. So I wouldn't want this group to walk away with a sense that we're just going to move to entirely N of 1 medical care.
Right.
It's much more promising and profound than that, in my opinion.
Well, we have a long way to go because we had an N of everyone. I suggest that if, as diverse as this audience is, if they encountered the healthcare system and their blood pressure was high, they get the same starting dose of the same medication. That is absurd, but that's what would happen today. And so we have a long way to go before we have an N of 1.
Yeah. Maybe time for a couple more questions? Yes, over here. We'll get you a microphone. Oh, we'll get you next.
Yes, please.
I'm going to qualify this question in the context of why we measure so that we can learn. And I think what I'm struck by is the absence of how we are thinking about quality measurement to support a learning healthcare system. So I'd be curious to hear, as we enhance the quality measurement process with technology, what are some fundamental components of a learning system that leverages these innovative measurements we are talking about participating with technology?
I want to say that I think people are thinking about this. And OMA, that I referenced before, to me, that's actually, they don't use that term, but that's the paradigm that they're going to make possible. Now, it's currently in a research context that people are thinking about this. I actually think NIH needs to kind of reframe the way it sponsors research. The whole idea that everything is separable and stovepipeable, that shows the structure, it manifests in the structure of NIH, I think needs to be rethought. And they need to be kind of coming to the forefront with all the dollars that we spend on biomedical research and kind of encourage this kind of thing. So I don't have like a program, but I think the possibilities are really presenting themselves, and it'll be very exciting to see how we move that. And one of the things I think that how is that going to work from an accountability perspective? And how are patients going to feel about being part of a learning healthcare system when they currently have a paradigm that's much more certainty driven than it actually is? I mean, the kind of mindset of people is less aware of all the underlying diversity. So I don't know. There are some questions that you have to wait for them to be ripe to be answered. And I think, thank you for a wonderful question and something we really need to think about, where I don't think the answer is going to be obvious today, but maybe next year or in a couple of years, or we'll start down a path.
I think the learning health system was always there. You just didn't like how slow it was.
17 years, right.
The time gap between the knowledge generated in the scientific community and its absorption in the clinical community is absolutely staggering. I won't talk about the reasons for that, except to say that the barriers that exist can be torn down when we realize that funding gets in the whole picture. I spent my youth at NIH. I used to be an oncologist. I think that we focus so much on the funding aspects of research and its delivery to the clinical community that we lose any credibility about the application of that scientific knowledge. And so for a virtuous system to be a true learning health system, some of those barriers need to be removed. And I think generating quality data will help move that along.
I know we said we had one more that we'd get to, and I'm getting the sign that we need to wrap up. Can we take one last question? Okay, if you could pass the microphone to your colleague at the front there. Thanks.
Thank you. This is really quick one. On Jean, is that an advisory group? I'm thinking of
Yes, ma'am.
another paradigm.
Can you say that again? We didn't hear.
Jean, therefore, with an advisory group.
Oh, Advent.
But I was thinking of another paradigm shift, and especially when you're talking about sort of health care data literacy, which is the other spectrum. I often think of my in-laws who passed away a couple of years ago, and sort of a group of people, maybe a large group of people who are very dependent upon the medical industry, their doctors in particular. So whatever the doctor says is what they do. And I often think of those people as we talk about data, as we talk about apps, and we talk about all these things that we're going to give people. And I think about my mother-in-law who passed away in a very unfortunate way, really dragged out. And she was given information, so that she didn't know what to do with. And I think of those people a lot. So, and obviously we're at a digital conference, but every conference I go to, I hear a lot about data, digital revolution. But I often think about the patient that's going to get this data. And how much time are we spending thinking about the people who, that maybe are not savvy, or who, I think we built this system where we do have a dependency sort of on the doctors and the healthcare system. People don't have access to their medical records. There is this kind of black box of, I'm getting treated, I'm prescribed medicine, but I don't really even know what my medical record is. So again, I just wanted to sort of raise that point. It's another end of the spectrum when you talk about sort of healthcare literacy, the folks who have access to the information, know how to use it, but don't do it. And then this other side of it, which is, folks who, again, are very dependent upon their doctors and their systems to tell them what to do. And now we're giving them the information to make decisions themselves.
I don't
We've got
know.
it.
Yeah.
We've got it. Yep. Go ahead, Peggy.
I'm not sure that that's actually the model. I mean, first of all, I think there are very deep differences between different segments, age segments of the population, right? Young people, I think, are going to be using healthcare. I mean, they're ready to use it very differently from older people. And of course, they're healthier, so that makes it simpler. But, we've met with a number of app builders and so forth. And the model is not to necessarily present you with your data. It's to kind of take it and make it user-friendly and so forth. So, I mean, the possibilities are there to make it extremely user-friendly and be more present in a way that it didn't work when it was visit to visit. It doesn't mean that it won't be done poorly. I mean, the execution is everything with this stuff, and it's not simple. So.
Yep.
I wanted to let Peggy have the last word. So after I drop this bon mot on you, around the corner at Harvard and MIT, they both did some calculation on patient mortality. One institution had a different estimate than the other, but that is that we physicians provide care in which 250,000 Americans have avoidable medical deaths. It's the third leading cause of death in the United States. Suppose they're off by a factor of 10 and we only kill 25,000. We're not doing a really good job. So part of this learning health system, which we focus so much on the reliance, because if my air conditioning broke down, I'm not going to get 3 air conditioning specialists to come in and give me advice. Maybe it's not a fair comparison, but at some point you just have to rely on the advice of the professionals, and we need to go a lot of steps further to improve care, and I think being able to measure it is one such avenue. So I'll defer to you.
Thank you very much.
Yeah, I would just add to that and say, we're certainly not going to go down a path that gets to personalized medicine and not personalized care. So we have to recognize that different individuals will have different receptivity to tools and information. And in every conversation I'm in with clinicians, they are highly aware of that. In fact, it's one of the concerns I hear expressed about the tools that are there. So I think that would go low on my list of things to worry about. I think we'll see that addressed pretty well. I've got to thank Peggy and Chuck for a really, really interesting set of insights, a great conversation, a really important start to the day. All of us are rooting for you in this collaboration and standing ready to lean in and support you in the ways that you need from us to get this important work done. Have a fantastic day, everyone. Work hard and take away some important take-homes